Good day, everyone, and welcome to the CVMA's weekly town hall for navigating through COVID-19. My name is Melanie Hicks, and I'm the president of the CVMA and the moderator of these sessions. I'd like to take a moment to thank Hill's Pet Nutrition for the generous sponsorship of this series. I'm joined again today by Dr. Scott Weiss, who many you are familiar with him from the previous town hall sessions that we've hosted. So he's a diplomat of the American College of Veterinary Internal Medicine and a professor at the Ontario Veterinary College. Before I hand it over to Dr. Weiss, I just want to remind everyone that this session is being recorded and will be placed on our CVMA website. Any previous questions that we may not have been able to address due to time, the answers, whether they be legal and such, they are all on our CVMA website as well. So I would encourage you to go there to look at some previous sessions and unanswered questions that we now have answers for. We would encourage you to use the chat box freely. Any comments, questions that you would like to provide throughout today, it's really helpful. Any comments on what you want to see for future sessions are also going to help us. So I will be monitoring the chat box, as will Dr. Weiss, throughout the session, and I will turn it over to you, Scott.
Great. Thanks a lot. Let's get my screen up here. Okay. Thanks, everyone, for coming back. So the rundown for today is once I get this going. All right, that should be good. Okay, so today I'm going to expand on some of the updates. I'm going to spend more time talking about general COVID updates. You may be getting a lot of this already, so I apologize if this is repetitive. It's going to be more on the general COVID side than the animal COVID side. There's not been a lot of change in the last week in terms of animals, the odd case of an animal trickling in. But nothing really game-changing. So I'm not going to talk much about that. I want to help explain the scene as COVID in humans is evolving, because that's relevant to us in practice and our risks and the measures we're going to take, and things like travel, employees moving back and forth. There are a whole range of issues that it's really important for us to understand the human side really more than the animal side. CAHI's finished off their industry guidelines that were talked about a few weeks ago. So I'm going to hit on some highlights there. We have Catherine Fileski. She can jump in and add any detail or fix anything I mess up as I go through some of that. And then we'll have time at the end for Q&A if there are any questions that go through. In terms of our Canadian numbers, they've been continuing to increase, but slowly. Canada is doing fairly well now. It took us a while, I think, to get things controlled, but we're in a reasonable spot. You can see our numbers, 100,000 reported cases. The big number really to pay attention to comparing countries is deaths. Death is a pretty clear endpoint. Cases can be missed a lot more based on testing. You're more likely to pick up a case that dies than a random respiratory disease case. So it's important to look at both of those. And within the country, it's important to look at case numbers if testing is done the same. It lets us know our trajectory. But when we're comparing internationally, deaths is a good indicator between similar developed countries with similar healthcare systems. And just leading into that, looking at the U.S. The U.S. is a bit of a challenge still. And there are various reasons for that, some medical, some political, some equity, a whole range of things. This ties in for us because of our border, right? Because of the risks of things coming up, and because we travel to the U.S. a lot under normal circumstances. This impacts kind of our future in terms of travel for vacation, family, conferences, and the like. If you look at the U.S., look at total case number, they're over 2 million. But if we look at deaths, which is that more standard number, 116,000, that was from CDC. There's a little bit of discrepancy in some of the new numbers. It's a little bit lower on this than we've seen elsewhere, but the general idea is 100,000 plus cases. Latest modeling in the US has them back up for 200,000 or so by fall, but it really depends what happens. And if we look on the right here, this is the start of our general epidemic curve, right? It starts low and then boom, takes off. And we typically like to see in an outbreak is things start to, tail back down. We want to see that nice bell curve. And it's relatively flat. And the concern is it going to stay flat or is it going to shoot up because of the relatively uncontrolled opening in some areas of the US, because of protests and the like that have brought people together in close circumstances. So, this isn't here to criticize the US and say we're good in Canada, because we've screwed up a lot of things ourselves in Canada. But it just poses the risk that we have an ongoing basis with that large border, and how that border is probably going to be closed for a while. And when that border gets opened up, we still need to be thinking about how we're going to travel there and what we're going to do if we have staff that are traveling to the US, which is a high risk area. And we talked about that a little bit with Doug Jack. That might get brought up again next week with some HR issues, but thinking about how we move and how our staff move once things get loosened up will still be important, and understanding the risks in different areas will be a key part of that. Back to Canada. So everyone's really familiar with R0 now, that half the country understands what R0 is, and no one did before that. So this is our reproduction number. Essentially, it's the number of people that get infected by a person that's infected. So if our R0 drops below 1, that means your average person infects less than 1 person. So the disease will fizzle out. If it gets over 1, it means we're amplifying it. And you can see where we were back in March and April. We kind of hovered around R0 of 1 in April, May. In June, we've been consistently heading down. So that's good. There's still transmission, but it means that it's slowing down or it's dying out because your average person, not everyone infects someone, essentially, right? So we only see 60, 70 infections for every 100 initial infections. And it varies across the country. Ontario has been the laggard here for a while with the most number of cases, along with Quebec. And Ontario is getting things under control now too. The last R0 for Ontario, this is from David Fistman from a couple of days ago, was about 0.5. And the numbers vary a little bit, but consistently we're less than 1. You can see we've got a couple places where their R0 is at 1 or above, but the confidence intervals are pretty big because they're small numbers, smaller populations. So in Canada as a whole, things are looking fairly good. Now, the big thing for us as things get reopened is what happens to those numbers, because there's a chance they're going to shoot up, obviously, as we get more and more contacts. And shooting up a little bit is okay, shooting up a lot is not. And just thinking about the contact increase, this is a busy graph, but it highlights a couple things. And for me, it highlights when you've got things under control, you can be more flexible. So if you look at the bottom right here, this is the contact rate increase. So these are different scenarios when you get more contact, more potential transmission based on where things are right now. New Zealand's in a great spot because they had eradicated it. Now they found another case, but they've got it very well controlled. Germany had big issues. They've got it fairly well controlled. So when you increase contacts, you don't have much likelihood of a large increase in cases. If we look at California as an extreme, if you start increasing contacts, your case numbers will go up quite substantially. Ontario is fairly similar, although we're probably better. This is from a couple weeks ago now, and things have trended down quite nicely in Ontario. So you can probably collapse that a little bit. But essentially places that haven't been containing it, like Sweden, like some places in the US, the more you increase contacts, you get that exponential increase in potential risk. So again, why we're paying attention to distancing and why we need to be careful with what we do. Economic impact. The farther away you get from here, the bigger the economic impact. One interesting point is Sweden. Sweden's had a lot of attention because they didn't get very restrictive at the start, and they walked that back a little bit and kind of said, oops, we should have done more than we did. Their economic impact is still fairly big, and economically, they're not probably going to escape much better than other Scandinavian countries, despite having much higher death rates. Again, showing the importance of restriction and the fact that restriction is going to contract growth or contract your economy, but this disease is going to make it happen anyway, right? So restriction is going to lessen that health impact while probably having the same overall economic impact. US just kind of comes back to the US. If you look at some of the hot spots right now, over the last week or so, places where case numbers are increasing tend to be in the south. New York was a hotbed initially. Disease rates are dropping quite well there. Southeastern US, kind of general in the south, some parts of California and Washington State has flared up again a little bit. And I guess one of the things is, we tend to travel to a lot of these areas. So again, it's reinforcing some of those travel risks. And just to show the impact of some of those areas, think back to that Canadian data, we had 8,000 or so deaths. 2 of these counties in the US could account for all our Canadian deaths. So again, the massive impact you can get in some areas that we escaped, right? If you think back to what was happening in New York, where they were bringing in refrigerated trucks and digging mass graves to try to keep up with all the deaths. People have forgotten about that fairly quickly. So this kind of a significant impact, which is why we're still doing what we're doing. This, I think, is really relevant for us. So this is a comment from an infectious disease physician. They're talking about reopening. And basically, they're talking about small spaces. So I think this message we need to be preaching for the reopen. Everyone needs to be avoiding these areas, and employers need to consider these as people get back to work. Break rooms and small meeting rooms probably infected more healthcare workers than patients. This is from an infectious disease physician again. So this is a really important statement for me, right? So what this says is, his assumption is PPE worked really well in hospitals, and people weren't getting infected by all these sick patients. They were getting infected because they stopped wearing the PPE and they did the things that we know are high risk amongst themselves, right? So they worked really hard with their PPE in the hospital room, took off their PPE and relaxed in a break room. Or in a meeting room, didn't have that same distancing, didn't have masks on, and that was actually potentially a higher risk situation than intubating a patient with proper precautions. So this is obviously relevant to us because we have break rooms, small meeting rooms, small confined places, and everything gets back to the risk being indoor spaces, poor ventilation, small spaces, and droplet generating procedures like talking, yelling, singing, laughing, coughing, all those things. And again, that describes a veterinary clinic. Lots of small rooms where we can get within 6 feet quite regularly and where we're communicating with poor ventilation. So again, something to think about when we think about how we handle ourselves with clients, ultimately if they're back in the clinic, and how we handle ourselves in clinics with our staff, in treatment areas, in reception areas, in meeting rooms, break rooms, lunch rooms. Switching topics a little bit. This is one, I think it's good for us to be aware of what's going on. We're not going to be needing this to treat our patients, presumably, but it's useful to have an understanding of what's happening. Low-dose Dex has gotten a lot of attention on us. I think it was a couple days ago, there was a radio story coming on. It was saying, okay, they've got this new steroid. And my brain's kind of thinking, new steroid, that's kind of interesting. It said dexamethasone. It's like, holy crap, that's farthest from a new steroid that we got. But the study from the UK, looking at low-dose dexamethasone and showing pretty substantial improvements. And looking at death. So, death is a pretty solid indicator. You're dead or you're not. It's not subjective like, how did you feel? How many days off oxygen? I mean, this is a very clear endpoint. So the dose they were using was 6 milligram per kilogram orally or IV. That corresponds, guesstimating person size, like 0.07 to 0.12 mg per kg range. So within the anti-inflammatory dose range that we use. And what they showed was by using that, they had about a 35% reduction in deaths in people that were on ventilators, 20% reduction in deaths in people that needed supplemental oxygen, and no impact on people with mild disease. Reinforcing the whole issue that when these severe diseases happen, there's this profound inflammatory cascade, and suppressing that inflammatory cascade is really the key. And this kind of ties into a couple things. Some people have said, well, I'd rather just have this virus now and get it over with. And, best case scenario for you is you had a mild case 2 months ago and you're immune. That would be nice, but you don't know when you're going to have the mild case. And the counter argument to that is, well, if you're going to get this virus and you don't know if you're going to be really sick or not, you're better off getting it later on because we might have better treatments. So this could save a lot of people that might have died a month or so ago. So there is a lot still being learned. So the good things from this study, it was a large study, it was a clear outcome measure, it was a randomized controlled trial. I can't spell apparently, but it's a cheap and accessible drug. We don't have a lot of data on it, and it's still getting some criticism because, this is, science by press release is how this is all described. Everyone's sending out their information by press releases, and this is on Twitter where they're announcing it without even going to a preprint article. So not even a non-peer-reviewed article, nothing at all. But, in strange times, this is important information to get out. So a lot of decisions that get made with, questionable data, and you hope those data hold out, and you hope they're like hydroxychloroquine. Getting into masks a little bit here. Again, this is how we think about how we behave. This is a preprint study. So again, preprint studies are papers you can upload to a preprint server. There are a couple of them, and they haven't undergone peer review yet. It's a way to get information out there so people can see it, but you have to realize that it may or may not be any good. This seems to be a fairly good article kind of at first glance. And what they did is they looked at the mortality rates and they based it on time since the infection was identified in the country and whether masks were used. So did they implement a mandatory mask procedure very quickly within 15 days of the onset, a little later within 16 to 30 days, or did they implement no masks? And this is consistent with what the observations have been with countries that were very aggressive with mandatory masking policies, as the rates stayed low. And when you don't have mandatory masking, your rates go up. which makes complete sense. It's a droplet virus, right? So the more we keep it contained in a mask, the more impact we have. And this shows a pretty profound impact. So just one more piece of evidence to show the importance of masks. And this is important to think about how we're using masks routinely and understand why mandatory masking is really being pushed. So this is, as of last week in Guelph, the Medical Officer of Health issued an order, and this is a legal order under the Health Protection and Promotion Act to mandate mask use in any commercial situation. So a vet clinic would be part of that. So it's a legal requirement for all personnel in the clinic and for all clients in the clinic to wear masks, and a requirement for people running the clinic to make sure that their staff and their clients are wearing masks. This is going to be more, there are other places that are doing this. This is going to be more common. So if it's not happening in your area, you still need to be prepared for it, be thinking about it. And it also just gives good weight for you to do this yourself, right? Mandatory masking in a clinic makes complete sense. Doesn't matter what your medical officer of health says right now, whether it's required or not, because that's often more of a political question, how much they're willing to put their neck on the line. But we are going to see more of these. So for masks, it's best to require masks for anyone in your clinic. Personnel, if you bring clients in, make them wear a mask. It's easy, it's cheap. There's not really a downside. It's annoying, but it's becoming very common, very normal. Like, you feel weird when you're doing it at the start, but it gets very normal. If you have a mandatory masking requirement in your area, you have a requirement to make sure it gets done. And that's your staff and your clients. It also means you need to pay attention, right? If someone comes without a mask, you need to be able to provide them with a mask or send them away. So we need to be thinking about sourcing masks, whether it's disposable non-medical masks. We have a box of them by the door for people that didn't bring their own, or they have a cloth mask that they use and then they leave behind and they launder. There are various ways to do it, but we have to figure out a way to make sure that, if your staff forget their mask, you've got something for them, or if clients come without their mask, because people might just forget. It's not they're being belligerent. They might have forgot they didn't have one in their pocket when they left the house. So businesses are going to have to be doing this. If you don't have a mandatory masking requirement in your area, act like you do, would be my recommendation, because it might happen anytime. Like, everyone is one super shedder away from an outbreak in your town, city, area. And that might be enough to trigger a masking requirement. And the other thing is, you're just protecting your health and the health of your staff and the health of your clients. So I would, again, I've harped on this a lot, but I would seriously be thinking about mandatory masking if you're not. Now, the whole social bubble thing keeps coming up a lot. As things get restricted, the whole concept of, you're socially distancing within your household, now you're going to expand that to a bubble. And the question that comes up related to clinics is, should we treat a vet clinic as a bubble? So I'm just going to treat, the clinicians and the staff and the support personnel as one unit. We're not going to mask. We're going to hang out together because that's our bubble. And, there's some argument to that, but the problem is, it's when you get all these bubbles. So we got a bubble at the clinic, and then you've got your bubble, your family at home, and then your kids have their bubble at school, and you've got your relatives, your family friends, and your whatever soccer team, dance team, whatever it is, and then personal friends, and each of those have your bubble, and eventually you're in this big toxic bubble bath where everyone's kind of exposing everyone else. And this is the problem with bubbles. It becomes a slippery slope because these bubbles always overlap. So it's not just a matter of saying, I got this group of 10 people and we're good. We need to think about how those groups interact. So long story short, within a clinic, because you can have so many different people and because you're at higher risk, the more they expose people, it still is ideal to use proper precautions in the clinic. So keeping distancing up and wearing PPE, because the fewer bubbles you have, the lower risk to you and the lower risk from you. So while it's tempting to say, okay, well, we're just going to, treat the clinic as a bubble and not mask and not stay apart, it's probably not the best thing for us to do. So summary, hopefully this wasn't all too redundant, but we're doing a pretty good job in Canada now. Ontario, it took a while to come down, but it's coming down. But your low incidence areas are one person away from an outbreak, right? One infected person can affect a lot of people in the right circumstances, especially as we stop distancing. You get one person in a bar, a sporting event, something with a lot of people, that can be a big cluster. Low risk travel isn't on the horizon, especially to the US, but we still need to be thinking about it as we get into fall or whenever that might happen, is how we're going to work within the clinic to reduce the risk of people moving back and forth. We still have some deficiencies in testing, especially in contact tracing. Masking is getting better. Social behaviors are are good, but they're starting to slip a little bit. And we just need to remember that opening and return to normal are the same. What we want to do is open up as much as we can while doing things to reduce the risk of that opening. And one of the big challenges we have with infection control overall is success always breeds complacency. So as things go well, we forget why we're doing them. And that's something we'll have to be on the lookout for. Okay, so I'm going to move into this. I was hoping to get a little bit quicker. Sorry, Catherine. Catherine Flesh is going to be around for a little bit. So I'm just going to introduce the CAHI guidelines for industry visits, and then we'll let Catherine jump in if there's anything to clarify. And if you have any questions, start firing them into the chat box so we can get to those, whether it's the guidelines or something else. So these are guidelines for industry. They're recommendations for how visits to clinics, to farms, and the like will be managed. It's a voluntary group. CAHI doesn't have a regulatory power, but it's a good national organization. And I think my expectation would be any company that's coming into my area is following guidelines such as this. It's voluntary, but it could be expected. Individual companies can set stricter guidelines, and some certainly will, but this gives us a basis of what we should be thinking about when it comes to people coming into clinics. The other thing is, you know, if it's your clinic, it's your clinic. You're the boss. You can say who comes and goes and what they do. So you can set additional expectations. And it might be you see people sooner or later than the clinic down the road, or you do different things. But we want to keep a base level of precautions, and that's what these guidelines are for. And Catherine, jump in if there's anything as we go along. I see you're online there now. So I'm not going to go over the whole document. You know, you can read as well as I can. I'm going to pick out a couple of the points here, and just some of the highlights. There's a kind of a bullet point version and one that has more fleshed out recommendations. It's really more designed for industry. So just a couple of points here. So the first one there, all interactions should be driven by the comfort level and needs of individual customers. Just supporting what I said before. The clinic should be comfortable with what's happening. If you don't want someone coming right now, you know, put it off. We're not keeping it forever, but make sure you're happy with the fact that it's happening and how it's happening, and ask questions, right? A good company that set up their things really well should be able to say to you, here's exactly how we're doing things, because we're doing that to minimize the risk to you and to our staff. Industry reps should keep detailed logs of all interactions and field calls. It's something for clinics to think about themselves on the flip side of that, documenting anyone that comes into your clinic, especially the back end of the clinic where there might be different types of contact. Just if there's ever a problem, there's contact tracing. Now they want industry to do it. So if one of them gets sick, you can see who they've been exposed, or if they get sick, they can figure out where that exposure might have come from. But the bottom point kind of reinforces the fact that as much as you can do kind of existing distanced efforts, keep doing them. So we may not ever be back to the, you know, everything's done in person, because there are some advantages to doing things remote, just like, you know, veterinary medicine. Some basic things, there should be physical distancing requirements. This is a default for everything that we do, right? Stay apart. The biggest thing we can do is stay more than 2 meters apart from someone. It doesn't matter what else is going on. If we can do that, we reduce the risk greatly. Employers should provide their reps with hand hygiene supplies, masks, whatever it's needed. You shouldn't have a rep that comes in the clinic and asks for a mask or ask for hand sanitizer. So they should be well supplied. That should be their expectation. It should be kind of plug and play for you, that it's all set up on their end. They can come in and they've got everything organized. You know, they wash, sanitize their hands before they come in. Appointment only. We've talked about this a few times. What we want to do is regulate traffic in clinics. We don't want people congregating. We don't want unexpected situations. So the more this is by appointments, whether it's, you know, medical care or visitors or repairmen or whatever, it can be structured so you don't get a bunch of people coming in at the same time. So calls should be appointment only, and they should be on time. And if they're not going to be on time, they should call you and say, okay, does 2 o'clock still work? No, it's bad traffic. And if it's okay, well, no, we've got something going on, and just reschedule it. Industry reps should consider a checklist to ensure the customer's pre-screening and other requirements. So is everything all set for us to go there? And you know, every time you walk into any type of medical office, for sure, dentist office, you'll get the question, you know, are you sick? Have you been exposed to someone that's sick? That's basically the greeting now, right? We're going to stop handshakes. We're going to say, are you sick? You know, at some point, we're going to hope to get to the point where we don't have to, because everyone's going to know to stay away. But it is fair to say to someone when they come in, are you sick? Have you been exposed to someone with COVID? Just to confirm that. Another recommendation, limiting the number of field calls reps do in a day to reduce the risk of inadvertently spreading it. So just, you know, it's decreasing fuel to fire. The more numbers of contacts and the more spread out those are, geographically in different areas, the greater the risk. So limiting that, especially at the start, can be useful. Right, and again, just more from that fuel for the fire component, fewer people is better. So ride-alongs, coaching days, co-travel should be avoided if at all possible, because it's better just to have one person coming into the clinic than two people coming into the clinic. Two people's obviously double the risk. CE programs and other meetings with multiple individuals should be delivered remotely when possible. Kind of same concept, but this is all not rocket science, right? But it's good, basic, practical infection control. And if you can meet outside, meet outside. The more we can do that for everything, the better. You know, it's not going to work in Winnipeg in February. Or Winnipeg, no offense, but it's not going to work much in Canada in February. This time of year, if you can meet outside in a picnic table, stay 6 feet away, the risk is exceptionally low. You add on a mask, if you're getting closer, the risk is exceptionally low. So there are some, again, common sense things that we can do to reduce the risk. And then, so I said before, this is a droplet virus. This is respiratory transmission. The role of fomites is really not all that clear. The virus doesn't live very long. And if there's a fomite contaminating things, you know, there's a person with it that's probably greater risk. All that said, we're trying to minimize cross contact. So CAHI's guidelines have the same approach. So, you know, if you can send materials in advance instead of handing them over, that will help. If they can avoid, you know, avoid handing things off directly, avoid leaving things, avoid sharing things, avoid touching something that someone else is going to touch. You don't have to be worried about, you know, I touched a doorknob, so we're all going to die. It's just trying to reduce the number of unnecessary transfers because we don't understand the risk of inanimate objects. It's certainly much, much less than that droplet and that direct contact risk, but there is some risk there as far as we know. Travel into and out of COVID hotspots should be avoided. So this might be a situation where if you're in a clinic in an area where there's more disease activity, people aren't going to come. And that's, you know, you shouldn't be upset at your reps for not coming. You should be thanking them because they're, you know, doing things to reduce the control of disease. So there may be differential access to clinics based on what's going on with COVID in the area. And this would apply to some companies more than others, depending on how their reps are distributed. So interprovincial travel should be discouraged, and it's restricted in some areas, especially some Atlantic provinces. But again, the more distance that's involved, the greater the risk, just because of that traveling time, people getting on the planes or whatever, but we're moving from areas that may be higher or lower risk to different areas. So you may see less travel. You may see less visits from reps that have to cover large territories because they're not doing as much widespread travel and not doing overnight stays, except for certain extreme circumstances. So there will be changes in how you interact with reps, and those are going to change by company. And I think we just have to accept that and realize it's being done for our protection as well. So that was the really quick version, hopefully not too quick. Catherine, did you want to jump in and see if there are any, if you have any questions on this, feel free to fire them in the chat.
We don't have any questions currently or comments. I don't know, Catherine, if you have any comments.
No, thanks very much, Scott, for covering off sort of those major points. I think one thing that we wanted to emphasize just from an industry perspective was that, you know, we were very conscious of the reopening guidelines that were put out for vet clinics, and we worked quite hard, I think, to ensure that the guidance that we were putting out to our companies was going to work well and complement those well. And I hopefully think that that's reflected in the current version. The other thing is that this is our sort of initial guidance. The other thing we have committed to doing is to reviewing and potentially revising, if needed, these guidelines on at least a quarterly basis. And if things shift really radically between now and September, then we'll obviously sort of revisit them again. But these are very much sort of a green document that will be updated as needed and will reflect sort of the Canadian context as much as possible.
And can you comment on availability of the document?
Yeah, I think so. At this point in time, it's been distributed to the CAHI membership, including our associate members. I think we'll look at actually posting it on the CHI website as well to make it publicly available. We're still working on that because we're in the middle of a few other things right now. But in the interim, if anyone would like a copy of it, then by all means, either reach out to me through CVMA and would be happy to provide it. Scott has a copy electronically, so you feel free to share as well, Scott.
Okay, so we'll post that on Worms and Germs blog as well, as long as that's okay, Catherine. Just so
yeah, that would be great.
Okay, so that'll be available, and I guess that's one of the questions just came through is how they'll be available. So you'll have lots of ways to get it. It's the take home. And I guess if you download it once, it wouldn't hurt to go back to that site. I don't think you can probably predict when it might be updated because it's going to depend on how things change. But just realize we download it now, it might not apply in September if there's a revised version.
And we will certainly, I mean, if we make major revisions, then we will communicate that to CVMA and RVTTC and all of our other stakeholder groups. So we would make every effort to ensure that everybody knows that there have been changes made when they are.
Great.
Perfect. And we could post it on our CVMA website as well under our COVID section, if that's okay with you as well.
Perfect. That would be great.
Great. Okay. Well, thanks a lot. If there are any other questions, feel free to put them up. And I know Catherine had to run for something at some point, but we can always forward any questions to her if they come in and she's already gone, or if you think about them after the talk. Okay, we don't have a ton of time, just a couple more things. And if there are any other general, I want to leave a few minutes for general Q&A. I see we've got a couple questions there we'll get back to in a minute. But if you have other questions, please feel free to put them up. This is a document you might have seen before, especially if you're in Ontario. So this was a revision of guidance for veterinary care in the COVID era. It was updated 2 weeks ago, a week or so ago, recently. A new version out as part of Ontario moved to what Ontario considers to be stage 2. It does apply pretty much everywhere. There are different nuances for your area depending what's allowed and what's not allowed. But this gets into bigger picture concept of how do we maintain distancing and maintain veterinary medicine, telemedicine. How do we run exam rooms? What do we do to consider when to let people in the clinic? What do we do for PPE? We brought in a few new tables and the like. So this is available through OVMA. It's also available on Worms and Germs blog. And if anyone else wants to post it, you can put it anywhere else. So we just want to get the information out. So a couple of things on there. I'm not going to go over these tables, but just to show some of we're getting more detail in terms of PPE because people still have a lot of questions about PPE, about when to use masks, what type of masks to use, and really what they're designed to do, how face shields apply. So like I said, I won't go over that, but that's in that document, as well as, and this hasn't changed from the previous version, some recommendations on PPE for different situations, such as when you're close to someone, you can't maintain that physical distance, or the other extreme when you're dealing with a cat with an aerosol producing generating procedure, and that cat may have been exposed to someone that's infected and they have signs of respiratory disease, so our highest risk situation. Just one last quick thing. So I was at the dentist on Monday, and it was their first day opening, so they were a little bit freaked out too. So they're going through the same things we are. And they have a lot of debates on how to handle aerosol generating procedures. And in Ontario, the dentist college is battling the hygienist college. The hygienist college wants a lot stricter level of infection control, just to show that things are changing. We don't really understand a lot of it. The reason I brought that up is the face shield. And what the dentist wore was a chest anchored or chest supported face shield like this thing on the right. And I haven't seen many people wear them before. You know, our typical face shield attaches to your forehead. And the concern about face shields in general is if you're looking straight on someone, they work really well. They're a good barrier. If you're moving your head side to side, if you're looking up, or if you have something that's generating aerosols that are kind of hitting your body and moving up toward your face, then they're not working as well because they can bypass that shield as opposed to a mask. So these are something to consider, especially if you find yourself needing a face shield in a procedure and the way you are such that, you know, that gap at the bottom creates a problem. So you're sitting there and you're doing a dental and you're generating aerosols, and the way you're holding your head and the way that patient is, you know, that air is coming up underneath your face shield, you can get these bottom ones, these chest supported ones, where instead of resting on your forehead, they rest on your chest. So there's a seal. There are various ways you can do it. Essentially, the plastic starts right down at your neck area and it's open at the top. So depending on what you're doing, this is a consideration. You can buy these in various places. So when you start thinking long-term about, you know, the risk from animals seems to be fairly low. Dentals and cats that have been exposed are still our highest concern. And if there's another wave where we get a lot more infected owners, that becomes more a realistic concern. So it's just something to think about, as well as just for kind of our sort of routine PPE use. So with that, if there are any other questions, I see we have a couple in the chat. We'll hit on those right now. Is it necessary to wear a gown? We just wear a mask when outside talking with clients. A mask is fine, right? And, you know, talking to someone outside of the vet clinic is no different than talking to someone in the grocery store or outside somewhere else, right? It's still that interaction, and we're not going to wear gowns, you know, all day for everything. So what a gown is doing is protecting you from aerosols, and they get on your clothes. And the risk of an aerosol getting on your clothes from an interaction outside where you're trying to maintain as much distance as possible is, it's so low, it's not worth the effort. So, you're not going to the client and standing within a foot and they're slobbering on you probably. Then the gown might be an issue. If we thought we had a dog that was infected and that dog's running around your legs and licking your clothing, and that's a situation where a gown is going to be useful. But if we're talking to someone outside, outside is low risk. If you can keep greater than 2 meters away, that's low risk. If you add a mask on, you've got another layer of protection above you. So a mask is really the key. If the virus dies on surfaces in 2 days, can I leave my mask in the back of my truck for over 2 days and reuse it without washing? Yeah, probably. Like the odds of a mask being contaminated are, again, it's thinking about what we're using the mask for. So most of the time we're using the mask to protect from us. So the odds of it being contaminated without you knowing are pretty slim. And if it's contaminated, then you already have it. So if you're using it to protect from someone, so a healthcare worker using an N95 doing an aerosol generating procedure is a little different story because that mask might be contaminated by that patient and we don't want to get them exposed. For our routine masks, really we're worried about what's come from us. So disinfecting masks that you've used to protect from yourself is less of a concern. That said, what's been said in this question is really true. If you just leave a mask for a few days, it should be fine. So with the active surveillance we do, where we're testing animals from exposed people and going to households, I have N95s, and I'm saving those N95s so when I run out, I can go back to an old mask. And the virus is going to die in maybe even less than a day. If it's in the back of your truck for a couple of days, especially in warm weather, that virus is long gone. Washing still is a good idea if it's a cloth mask, just because you get secretions and it'll start to get clogged or start to get, just visibly dirty. But from a decontamination standpoint, yeah, the virus will die fairly quickly. I've seen a lot of people hanging masks in the car below the rearview mirror. Sure. Yeah, it's going to be exposed to sunlight. It's going to be exposed to heat when you're in the hot weather, when the car is closed up. Yeah, it's going to be a really good way to decontaminate it. I'm not too worried about, if you're using the mask for yourself, I'm not too worried about the contamination component, right? Because again, if I contaminate my mask with this virus, it means I have this virus already. So it's more of a risk for other people to handle my mask. But that's going to be a way to eliminate things on it for sure. Any preliminary data on a study with pets to share? Not yet. Our recruitment has slowed down quite a bit. Part of that's good because we don't have a lot of cases. So this is the study where we're going and we're sampling animals in households with infected people. And we aren't seeing many infections in this area now. So that's dropped our recruitment. So we're trying to get our numbers up. We're starting a seroprevalence study right now, basically. So the PCR-based study lets us know who's actively infected. And that's a bit of a, it's a bit of a shot in the dark, right? Because person's infected and they infect their animal, it's a relatively short period that the animal's infectious. So we have a relatively short period to get into that household and find out if they're infected. By looking at antibodies, we can see if they were exposed in the past. So that's where we've moved our efforts now as our bigger study, looking at antibodies in pets owned by people that are positive. And that's just starting off right now. So we might have some results in a couple of weeks to start sharing with that. Any concern about inhaling bacteria from your own mask over time? Probably not. Well, if your mask is fermenting, maybe, but what's on your mask came from you, and it's probably not going to grow that much in there. You don't like if you were wearing this mask a long time, and you're saturating it. You're getting organic material on there. It's really moist, and it becomes a bacterial growth. So yeah, you might grow some things that are nasty, and that's why washing these makes sense, right? It's treat it like your underwear. Change it regularly, wash it well. And then reuse it. So I don't think we really know much about this. Like cloth masks, culturally they've been used in some areas a lot more as a routine tool, but no one's really looked a lot at how to use these in large populations on a day-to-day basis. So I would just say, try to launder them regularly. Like I certainly don't launder ours every day. It's kind of sporadic at best, to be honest. But if they smell, for sure, launder them. If they look dirty, for sure, launder them. But otherwise, still, even every few days is a good idea. That's why it's nice to have a collection of them so you can cycle them through. I think that's maybe all our questions. So if there aren't any other questions, if there are any questions, toss them back up. If there aren't any, then I'll turn it back to Melanie if I can stop my screen sharing.
I think this is one of the quietest groups we've had on our chat box for quite some time. So thank you again, Scott, for a great session, and thank you to everyone for attending today. And lastly, thanks to Hills for their generous support of this. And we look forward to seeing everyone next week. We have a new topic of discussion coming up, so I think will be a really good one for everyone. See you next week. Bye, everyone.
Everyone.